For decades, severe weight gain was treated as a failure of willpower, but morbid obesity is highly resilient. The body treats this excess mass as its baseline, deploying a locked homeostatic feedback loop to defend against caloric deficits. To see how aggressive this defense is, we can look at a 2-year clinical trial out of Stanford that tracked patients attempting to lose weight through rigorous dietary interventions. The study specifically controlled for genetic factors and baseline insulin levels, comparing a strict low-fat diet against a low-carbohydrate approach. This chart plots the 24-month trajectories of those two diets. Despite utilizing entirely different macronutrient profiles, the weight loss for both groups plateaus at the exact same threshold, a marginal 13 pounds. The diet stalled because human genetics actively resist starvation. As soon as caloric intake drops significantly, the body's metabolic rate slows down and neuroendocrine signals ramp up appetite, effectively neutralizing the behavioral change. Behavioral adjustments alone cannot breach this physiological defense. To achieve meaningful, sustained weight loss in morbidly obese patients, clinicians have to deploy systemic overrides, either through neurochemical manipulation or brute force structural engineering. Before attempting surgery, the first line of override is pharmacological. These medications are indicated for patients with a BMI over 30 who present with comorbid conditions or a BMI over 35 without them. The oldest tools in this class are sympathomimetics, like phentermine. These drugs force the release of norepinephrine, artificially mimicking a sympathetic nervous system response to neurologically suppress the patient's appetite. But elevating sympathetic tone carries an unavoidable cost. Patients face a strict 12-week clinical limit on these drugs due to accumulating cardiovascular stress, including hypertension and palpitations. Once the medication is discontinued, rebound weight gain almost always follows. Modern combination therapies aim for a more sustainable neurological intervention. Drugs like Contrave combine bupropion and naltrexone to manipulate both dopamine and opioid pathways simultaneously, blunting the internal reward system to dampen the drive for caloric intake. Other drugs target the gastrointestinal system directly. Xenocol acts as a localized lipase inhibitor, blocking the intestine from absorbing ingested fat. Saxenda, a GLP-1 receptor agonist, manipulates the hypothalamus while simultaneously paralyzing normal gastric motility to delay stomach emptying. While these pharmaceutical interventions successfully suppress hunger signals and inhibit absorption, their yield hits a hard ceiling, a total body weight reduction of roughly 5 to 10%. For a patient with severe morbid obesity, this reduction is clinically insufficient. They require mechanical rewiring. Bariatric surgery abandons the attempt to coax the body into compliance. It relies on architectural intervention, physically overriding homeostasis along two axes, restricting sheer stomach volume and intentionally forcing nutrient malabsorption. Because of the permanent physiological changes involved, the surgical threshold is high. Patients must have a BMI over 35 with existing comorbidities or over 40. The most common standalone procedure today is the gastric sleeve. It is classified as a purely restrictive intervention. Looking at this schematic of the upper GI tract, the sleeve procedure works by slicing vertically through the stomach. The entire greater curvature is permanently excised and removed, leaving behind a narrow, high-pressure tube. By drastically reducing the stomach's anatomical capacity, the patient is physically incapable of consuming large quantities of food. This pure volume restriction yields an expected loss of 60% of their excess weight. However, while the sleeve forces caloric restriction, it leaves the entire intestinal absorptive architecture intact. Every calorie that passes through the sleeve is still fully processed. To maximize weight loss, surgeons have to execute a deeper, more radical bypass of the anatomy. The Roux-en-Y gastric bypass is a dual-axis intervention. It compounds a restrictive stomach pouch with engineered malabsorption, deliberately disabling the small bowel. Surgeons isolate a tiny stomach pouch, bypassing the duodenum and proximal jejunum. The lower jejunum attaches directly to this new pouch. Food drops straight into the distal jejunum to avoid absorption, while digestive enzymes travel down the old duodenum, mixing with the food much lower. This dual mechanism, restricting input while simultaneously blocking the absorption of whatever does get eaten, pushes the expected excess weight loss to roughly 70%. For the absolute ceiling of surgical intervention, there's the biliopancreatic diversion with duodenal switch, or BPD-DS. This architecture combines a restrictive sleeve gastrectomy with a massive bypass of the vast majority of the small bowel. The common channel, the only place where food and digestive enzymes actually mix, is pushed to the far distal end of the GI tract. Achieving the maximum possible weight loss requires breaking the human body's evolutionary mechanics. The patient survives by actively resisting nutrient extraction. This anatomical rewiring guarantees permanent metabolic consequences. The patient relies on a deliberately broken absorptive system, trading one disease state for a lifetime of managed deficits. Returning to the Roux-en-Y anatomy, the bypass duodenum is where the body typically extracts heavy elements. By routing food around it, the surgery actively blocks the absorption of iron, vitamin B12, and calcium. These specific deficiencies are unavoidable. Without aggressive lifelong screening and high-dose oral replacement, the patient will face severe hematological crashes and collapsing bone density. The fallout also extends beyond the gut to the liver. When a post-surgical patient begins rapidly losing massive amounts of fat, the liver reacts to the metabolic stress. The liver attempts to process this rapid weight loss by dumping large volumes of concentrated cholesterol into the biliary system. This cholesterol pools in the gallbladder, where it quickly solidifies to crystallize into gallstones. Gallstones and severe nutrient deficiencies are predictable mechanical consequences of forcing the body to rapidly mobilize fat stores while blocking new caloric intake. This new anatomy also disables the stomach's metering function. In a normal gut, the stomach acts as a valve, slowly releasing digested material into the intestines. Without it, patients are vulnerable to an extreme failure of osmotic regulation, known as dumping syndrome. The syndrome triggers when a dense, high-sugar bolus drops undigested directly into the jejunum. Because this heavily concentrated load destroys the local osmotic gradient, it aggressively pulls fluid out of the surrounding vascular tissue into the intestinal lumen, forcing the bowel walls to distend. This sudden fluid shift triggers a systemic shock. The patient experiences intense physical distension, severe autonomic distress, lightheadedness, and an overwhelming physiological rush. While dumping syndrome is managed through diet, mechanical failures require immediate triage. Vomiting is common while a patient learns their new stomach capacity, but if aggressive vomiting persists past the 6-month postoperative window, it is a primary indicator of a stricture or stenotic lesion forming at the surgical site. The altered architecture also changes the rules of pharmacokinetics. Because extreme bypasses severely limit absorption time, standard extended-release medications will pass through the body entirely intact. Clinicians must switch the patient to dissolvable or liquid medication formats to ensure the drugs actually enter the bloodstream. For the diagnosing physician, standard anatomical assumptions no longer apply. A post-bariatric patient is operating a heavily modified, high-maintenance metabolic engine, one built with entirely new baselines, thresholds, and unique mechanisms of catastrophic failure.